Hello doctors, this is Dr. Hera Salman. Sorry for the delay. There was some problem in generating this streamline. Alright, so let's just start from this chronic hepatitis B and C. We have to, of course, definitely we have to cover gastroenterology. There's only one topic remaining and then we're going to start endocrinology then. Okay, so with this chronic hepatitis B and C, there are no specific physical findings to allow you to answer what is the most likely diagnosis. There is no specific physical finding by which you are going to say this is actually this thing without blood testing. So you have to always prefer blood testing rather to say, these are only the symptoms or these are only the physical findings on which we can say this is that disease. So both chronic hepatitis B and C are associated with developing cirrhosis and liver cancer. So you're going to see cirrhosis and you're going to see liver cancer not only in hepatitis B but in hepatitis C also, but can be associated with polyarteritis nodosa. Both can be associated. Hepatitis B, chronic, and chronic hepatitis C. Both of them are associated with polyarteritis nodosa, and in both of these cases you are going to see cirrhosis and liver cancer. For the diagnostic test, chronic hepatitis B has surface antigen positive for longer than 6 months as a matter of definition. Chronic hepatitis B has surface antigen positive. You are going to see surface antigen positive for longer than 6 months. So 6 months, longer than 6 months, if surface antigen is positive, that should be a case of chronic hepatitis B. Most cases are E antigen positive as well. You are going to see antigen also positive in this case. Hepatitis B DNA level by PCR is the best way to determine viral replication activity, because polymerase chain reaction will give you the exact count of virus, right? So this is the one which is the best way to determine viral replication. When you want to see whether the virus is replicating, means ongoing infection. In order sorry for that, in order to evaluate, you need to check this PCR level. Biopsy to detect bridging necrosis no longer has any significant meaning. Biopsy to detect bridging necrosis, just 1 minute. Yes, so biopsy to detect bridging necrosis no longer has any significant meaning. So for biopsy, especially if you just want to detect bridging necrosis, so it's now no longer has significant meaning. Terms such as chronic active or chronic persistent hepatitis are no longer relevant. Nowadays, we are not going to use these terms like chronic active or chronic persistent. In over 80% of patients with hepatitis C, the infection persists as chronic infection. Most of the time, those who are having hepatitis C in acute state, they actually don't know they have. They are asymptomatic in that particular stage. So once they become chronic, then only you're going to most of the time they are presenting like this. So since the acute viral illness is really filled with hepatitis C, there is often no precise way to determine the time course of the infection. Hepatitis C Pcr Rna viral load is the most accurate way of determining disease activity. So this is only you're going to confirm with the help of this PCR. Pcr Rna viral load will exactly tell you what's the count of the virus, so that you know that's only the most accurate way of determining disease activity. Acute hepatitis C is treated. There is a treatment of acute hepatitis C. Liver biopsy determines the degree of inflammation and fibrosis. So if you do the biopsy, definitely you're going to check the degree of inflammation, and you will definitely come to know whether there is fibrosis or no with the help of biopsy. And biopsy can help you understand the urgency for treatment if fibrosis is present or worsening. So this is very important in order to determine that should we start the treatment of fibrosis, or should we see that if there is any worsening in the patient's condition, then of course we have to go for this biopsy. The question on chronic hepatitis are most likely to be treatment question. They usually ask you the treatment. So what is the treatment? You have to treat chronic hepatitis B with any one of the following agents. We have certain agents and you have to treat your patient with any one of the following agents. Either you're going to use Ediforward or lamivudine or talbivudine or entecavir or tenofovir, especially in the case of pregnancy. In pregnant women, you're going to use this tenofovir and interferon, right? So etofovir, lamivudine, talbivudine, entecavir, tenofovir and interferon. In any of the following agents, you have to choose one. Right now, combination therapy has not been proven to be more effective than monotherapy in hepatitis B. So if we are considering the combination therapy, then you just need to remember that combination therapy has not been proven to be more effective than monotherapy in hepatitis B. So if it's possible to start only one, that is monotherapy medication, better do that. Now we are coming towards chronic hepatitis C. Everyone born between the years 1945 and 1965 should be tested for hepatitis C. The treatments are, you have to treat your patient when you are seeing symptoms, right? And most of the time acute hepatitis C, although treatment is there, but mostly patients are asymptomatic. And those who are, born between 1945 and 1965, they should be tested for hepatitis C, because at that particular time there was no screening of the blood. So the treatments are sofosbuvir, velpatasvir. For all genotype you can use sofosbuvir, ledipasvir you can use, sofosbuvir, daclitesvir you can use, elbasvir or this grazoprevir. So all the vir combination you're going to use, and this ombitesvir or paritaprevir or desabuvir or ritonavir you're going to use. So these are all the combination options you have. So for all the genotype, especially if we are considering only genotype 1, if there is an infection of genotype 1, then we have this ledipasvir and sofosbuvir, both orally. So if for all genotypes, we can use this sofosbuvir combination and velpatasvir, right? Velpatasvir combination and sofosbuvir for all genotypes. But if we are considering only just genotype 1, then we have to choose this ledipasvir and sofosbuvir, both orally. So these agents all have nearly equal efficacy when treated with oral therapy for 12 weeks, or more than 95% of patients will achieve a cure. So these agents all have near equal efficacy. You can use any one of the combination when treated with oral therapy for 12 weeks. So that is important, oral therapy for 12 weeks. More than 95% of patients will achieve a cure. Assess cure with Pcr Rna testing. Pcr will give you a clue whether your treatment is a success or is a failure. If you're using any treatment and if you're going to check Pcr after 6 months, if it's level, now if it's come down, it means that whatever the treatment you are opting, that is a success. But if you're going to see the increase in the Pcr Rna level, it means that whatever the treatment you are giving is not, having a beneficial effect on your patient. That's why the viral load is high in your patient. So you need to change your treatment. So which will show suppressed Pcr Rna viral load 12 and 24 weeks after therapy. So once you started therapy, you have to check PCR viral load 12 and 24 weeks after therapy. So 12 months is like 1 year, and then 24 weeks it's like 2 years. No, it's 20, sorry, it's not months, right? It's weeks. It's 12 weeks. So we have like 12 weeks means that we have in 1 month we have 4 weeks. So 4 3s are 12. After 3 months we are going to choose, and 24 weeks. So 24 weeks means that 4 6 are 24, right? So after 6 months you are going to check. So after 3 months and after 6 months you need to repeat the PCR RNA in order to see whether your patient is, the treatment, whatever the treatment option you are giving to your patient, that is a failure or that is a success. Now here are the hepatitis C questions. You will see what predicts the response to therapy. What predicts the response to therapy? This is always genotype, because we know very well if the patient is having genotype 1 infection, it's far better to use ledipasvir and sofosbuvir combination. But if your patient is having all the genotype infection, for all genotype, you can always give this sofosbuvir and velpatasvir, right? Then we have what tells if there has been a response. What tells if there has been a response to that particular treatment which you have given to your patient, that is PCR RNA viral load. If its level are increasing, it means the treatment is failure. If its level is getting down, it means that your treatment is, whatever you are opting, that is a success. You have started good medication. That's why PCR is getting low. Now, what tells the extent of liver damage? Liver biopsy, but rarely needed. Rarely we do liver biopsy, but we can always tell the extent of liver damage with the help of liver biopsy only. What is the most common wrong answer? The most common wrong answer, liver function test, AST/ALT. We are not going to check in these patients. Now, what are the adverse effects of hepatitis medication? This we need to know, because on the basis of adverse effects, we can evaluate, like, these patients should not get this type of treatment. Say, for example, interferon. Interferon, they are highly associated with arthralgia, thrombocytopenia, depression, leukopenia. So, you definitely are going to avoid in all these conditions. Ribavirin is associated with anemia. Edifovir is associated with renal dysfunction. So, if the patient is, compromised, kidneys are compromised, you are never going to start this Edifovir treatment. Lamivudine has no as such adverse effects. Now, Wilson disease. This is a disorder of abnormally decreased copper excretion from the body, right? So, this is a disorder of abnormally decreased copper excretion from the body because of a decrease in ceruloplasmin, and copper is not excreted and it builds up in the body, in the liver, right? You're going to see that excretion it's not excreted. So what will happen? They will be building up in the body, in the liver. This copper is going to be deposited in the liver, especially in kidneys, in red blood cells, in the nervous system. Why? Because there is decrease in ceruloplasmin, that is a carrier protein for copper. Only acute hepatitis C is treated. That's a point to ponder. We already did before. Now, what is the most likely diagnosis? In addition to all the previously described features of cirrhosis and hepatic insufficiency, you will answer Wilson disease as the diagnosis if you see. So, when your patient is presenting with neurological symptoms, if he's having psychosis or tremors or dysarthria or ataxia or seizures, so these are all neurological symptoms. So, if the patient is presenting with psychosis, tremor, dysarthria, ataxia, or seizures, so these are the neurological symptoms, and you must say that if the patient is having all these symptoms, there might be a case of Wilson disease. Always consider. Plus, Coombs negative hemolytic anemia you are going to see, plus renal tubular acidosis or nephrolithiasis you are going to see. So if your patient is having renal tubular acidosis, nephrolithiasis and hemolytic anemia with Coombs negative test, and he's having any one of the neurological symptoms, you can assess maybe this is a case of Wilson disease. Tip for us here is Wilson disease gives psychosis and delusions, not the encephalopathic features or delirium that you would get with any form of liver failure. So Wilson disease gives psychosis and delusion, that is important, not the encephalopathic features or delirium that you would get with any form of liver failure. Whenever the patient is having any form of liver failure, you may find some encephalopathic features, right? But here, in the case of Wilson disease, you're not going to see encephalopathic features. Now, the best initial test is a slit lamp examination for case of Fleischer rings. A brownish ring around the eye. They are going to see a brownish ring around the eye, and that is from copper deposition. So, this is all about copper deposition. This ring is actually the copper deposition. Copper deposits in Descemet's membrane. So, ceruloplasmin is usually low. Liver biopsy is more sensitive and specific and will detect abnormally increased hepatic copper. So, liver biopsy is more sensitive and specific, no doubt, and will detect abnormally increased hepatic copper. And definitely we are going to see ceruloplasmin is usually low in this case. So, the best initial test is, you need to remember, the best initial test is slit lamp examination. Now, this is copper deposits in Descemet membrane. Give a brownish ring. Just give me a second, please. I'm back. Alright, so the most accurate diagnostic test is looking at abnormally increased amount of copper excretion into the urine after giving penicillamine. So the most accurate, see the best initial one, the best initial is slit lamp examination, right? You're going to do the slit lamp examination because you need to watch this case of Fleischer ring, right? And now the most accurate diagnostic test. The most accurate diagnostic test is looking at an abnormally increased amount of copper excretion into the urine after giving penicillamine. When you just give penicillamine to your patient, if you're going to see the release of copper into the urine, thereby you get an idea, oh, copper level was actually increased in the body. Because of giving penicillamine, the excretion of the copper will be raised. So decreased ceruloplasmin level is not the most accurate test. This is the most common wrong answer. All plasma proteins can be decreased in those with liver dysfunction, including the ceruloplasmin as well, and cirrhosis. So if it's a case of liver dysfunction, if it's a case of cirrhosis, there you can see decreased level of plasma protein. So only detecting this decreased ceruloplasmin level is not the most accurate test. You need to remember the most accurate diagnostic test will be this copper excretion, especially when you just give penicillamine. So treatment, penicillamine will chelate copper and remove it from the body. Additional therapies are, you can give zinc. Zinc interfere with intestinal copper absorption, and you can give this trientine, that is an alternate copper chelating compound. So first of all, you should definitely go with this penicillamine option, but you have some other additional therapies also that you can give zinc, and zinc is definitely going to interfere with intestinal copper absorption, and trientine, an alternate copper chelating compound, you can also use in these patients. So you just need to remember the best initial one, that is the slit lamp examination, and the most accurate one, that is the administration of penicillamine in order to check the release of copper in urine. Now we are coming towards autoimmune hepatitis. Look for young women with signs of liver inflammation with positive ANA. More specific tests are liver kidney microsomal antibodies, high gamma globulin, that is IgG, anti-smooth muscle antibodies, and anti-liver kidney microsomal antibodies. So you have to see all this in your patient, especially the one who is young woman with signs of liver inflammation, and she must be having positive ANA. And especially if you do the most specific test, that is the liver kidney microsomal antibodies, you are going to check high gamma globulin, you are going to see an anti-smooth muscle antibodies, and anti-liver kidney microsomal antibodies you are going to check, especially in this case, because this is autoimmune, so you need to evaluate antibodies. The most accurate test is the liver biopsy. Biopsy will be the most accurate test here. You have to sorry about that, you have to treat with prednisone or azathioprine. So you have to treat your patient with prednisone or azathioprine, that you need to remember. Penicillamine cannot be used with allergy to penicillin. Of course, you have to use zinc or trientine as an alternative therapy. It's not a therapy actually, you just need additional, these are the additional findings or additional therapy we can say, but it's not actually a therapy. It's going to diagnose whether copper is going to be released, excreted once we give this zinc or trientine. So these are the additional therapies. Alright, then we have non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is subdivided into two types. First of all, non-alcoholic fatty liver, that is relatively benign and is not associated with fibrosis or malignant potential. In the case of non-alcoholic fatty liver, especially, you are not going to see any malignant potential. That is, it's relatively benign and is not associated with fibrosis or malignant potential. Non-alcoholic steatohepatitis is associated with inflammation and fibrosis and the potential to progress to cirrhosis. Just give me a second, please. You're not going to come here again. Alright, so this non-alcoholic fatty liver is relatively benign and is not associated with fibrosis or malignant potential. So there is no fibrosis association and there is no malignant potential for this non-alcoholic fatty liver. Non-alcoholic steatohepatitis is associated with inflammation and fibrosis. So if this is steatohepatitis, so in this case you are going to see there is association with inflammation and fibrosis. So associated with inflammation, associated with fibrosis, and the potential to progress to cirrhosis. Inflammation, fibrosis, and then cirrhosis. So this is all about NASH. NASH is non-alcoholic steatohepatitis. So NASH is potentially pre-malignant, but this NAFL, or you can say this non-alcoholic fatty liver, whatever the mnemonic you want to say, this NAFL, so this is actually benign and it's not associated with fibrosis or malignancy or malignant potential. But this NASH, this non-alcoholic steatohepatitis, is actually potentially pre-malignant. So this non-alcoholic fatty liver disease is an extremely common cause of mildly abnormal liver function test. Of course, you are going to see abnormal of mild but abnormal liver function test. The biopsy is the most accurate test and shows the microvascular fatty deposits. So you need to go with this biopsy. You would find an alcoholic liver disease but without the history of alcohol use. You would find an alcoholic liver disease but without the history of alcohol use. This disorder is associated with most likely this non-alcoholic. You're going to see that the association is with obesity or in diabetes, diabetic patient mostly, in case the one who is having hyperlipidemia, the one who is on corticosteroid use. In all of these patients, you may find this non-alcohol fatty liver disease. The most important issue is to exclude more serious liver disease. So management is with correcting the underlying cause previously described, and there is no specific drug therapy to reverse it. So our main goal is actually, that is the most important issue, to exclude more severe liver disease. Now we are coming towards model for end-stage liver disease, that is MELD score. Model for end-stage liver disease. MELD score predicts survival in cirrhosis and alcoholic hepatitis. It uses, so you are going to see actually the scoring system is actually a prediction of, especially it going to predict survival in cirrhosis and in those who are having alcoholic hepatitis. So we are going to consider some criteria, like we are going to see age, we are going to see creatinine, the need for dialysis, we are going to see bili levels and INR. MELD score is critically in prioritizing who gets a donor liver first. So high MELD is equals to death sooner and therefore a higher priority for getting liver transplantation. Because of the death sooner, therefore these patients are having high priority for getting liver transplantation first. Then we have benign liver lesions. Benign liver lesions, like the case of focal nodular hyperplasia. In the case of focal nodular hyperplasia, is a liver lesion that rarely grows or bleeds and never becomes malignant. So this is a liver lesion, of course. This is focal nodular hyperplasia, is a liver lesion that rarely grows or bleeds and never becomes malignant. The key fact for you is imaging shows central stellate scarring, which is how you know it is benign. So this focal nodular hyperplasia is from hyperplastic hepatocellular growth around an abnormal blood vessel. No treatment is needed for this case. In the case of hemangiomas, this is also one of the benign liver lesions, are mostly asymptomatic lesions. You are not going to find any symptoms in these patients. Found incidentally with a small number of patients experiencing right upper quadrant pain. Ultrasound, CT and MRI eliminate the need for biopsy in most cases. Lesions who are less than 5 cm get no treatment. Unlike this focal nodular hyperplasia, hepatic adenoma changes with hormone levels. Of course, you are going to see a change with hormone levels. And during pregnancy, it may grow and even rupture. These hemangiomas, especially in pregnancy. In pregnancy, everything, muscularized and vascularized. That's why you're going to see the rupture, even rupture of these hemangiomas in pregnancy. Adenomas can cause pain, but biopsy is the definitive diagnostic test. That is for sure, biopsy. definitive diagnostic. Because of adenomas have a small risk of malignancy, biopsy is more essential in adenoma than in other lesions. So we need to just remember this point, that because of adenoma have a small risk of malignancy, there is less likely chances of transversion or conversion of adenoma into malignancy, but still biopsy is more essential in adenoma than in other lesion. We have to evaluate with the help of this biopsy. Now we are going to see the table that compares these three types of liver lesions. First we have focal nodular hyperplasia, then we have hemangioma, and we have hepatic adenoma. So we are going to see central scarring on imaging in the case of focal nodular hyperplasia. No malignant potential with this focal nodular hyperplasia. If it's a case of hemangioma, you are going to see tuft of abnormal vessels, imaging diagnostic, and no malignant potential. But if it's a case of hepatic adenoma, it grows with estrogen, large ones may rupture, and small malignant potential. So small, because of the risk of small malignant potential associated with hepatic adenoma, this is the reason that we have to be very careful in doing this biopsy. So biopsy is more essential in adenomas than in any other lesion. But while these two, hemangiomas and focal nodular hyperplasia, they have no malignant potential. Alright, now we are going to start endocrinology. So endocrinology starting with the pituitary disorder. First of all, pituitary incidentalloma. Incidentally, you are going to see a lesion in pituitary. By definition, incidentalloma occurs in asymptomatic patient, the patient who is not having any symptoms. Tumor size determines the management. So whenever the patient is having a tumor whose size is less than 1 centimeter, you have to manage your patient by checking his prolactin level, and you have to do MRI on yearly basis. That is your main management plan. If you're seeing any tumor incidentally, then you have, or the tumor which is decreased very small in size, like less than 1 centimeter, you have to repeat prolactin level, and you have to do MRI again yearly. But if the lesion is more than 1 centimeter, of course you are going to do prolactin, of course you are going to check MRI every yearly. But you need to do some more testing, because now the tumor size is big, more than 1 centimeter. You have to do 24-hour urinary cortisol. You have to check TSH, T4, LH, FSH, insulin growth factor, and test visual field for evidence of optic chiasm compression. So optic chiasma can be involved. Okay, there must be a compression of optic chiasma. So you have to evaluate visual field testing also. Now, first of all, we are going to deal with this Anti-Cellular syndrome. Anti-Cellular syndrome is a disorder in which the pituitary is undersized. You are going to see very small pituitary, flattened, and even not visible on MRI. That is why we are saying this Anti-Cellular syndrome. Like cella turcica is empty. There is no pituitary inside. So where is the pituitary? Pituitary is undersized actually, and it's flattened and not visible. So this Anti-Cellular syndrome can be incidental finding, and it's associated with surgery, obesity in obese patient, and radiation therapy. However, 70% are idiopathic. We don't know the cause. When asked how to manage asymptomatic Anti-Cellular syndrome, you need to answer that check thyroid and adrenal function. That is important. For Anti-Cellular syndrome, you have to check thyroid and you have to check adrenal functions. Then we are coming towards Penn Hyperpicturism. In the case of Penn Hyperpicturism, the name indicates, Penn means all. You are going to see the whole functioning of the pituitary that is reduced. That's why the whole hormones which are released from the pituitary, they are going to be down, because they will be low, because this is Penn. This is all hypopituitarism. So Penn hyperpituitarism is caused by any condition that compresses or damages the pituitary gland, and tumors of many types can compress the gland, such as metastatic cancer, adenomas, and reticulocysts, and meningiomas, or craniophryngiomas, and lymphomas. So these are all the tumors of pituitary gland. And trauma and radiation are damaging to the pituitary. So conditions such as hemochromatosis, sarcoidosis, and histiocytosis, acts or infection with fungi or TB or parasite infiltrate the pituitary, destroying its function, and finally autoimmune and lymphocytic infiltration can damage the gland. So these are all the etiologies how the pituitary gland is going to be damaged. There must be anything like infiltrative disorder like hemochromatosis, sarcoidosis, fungal disorders, parasitic infections. There may be, the tumor which is actually responsible for the compression of the gland, like this metastatic cancer can compress the gland, adenoma can compress the gland, rethiclapsis, meningiomas, craniopharyngiomas can compress the gland, lymphomas can compress the gland, right? Then how your patient is going to present. The symptoms of Penn Hyperpicturism are based on the deficiencies of specific hormone. So especially the hormone which is deficient, you're going to see its special findings in that patient. So ultimately, anything that damages the brain, from tumor to stroke to infection to trauma, can cause Penn Hyperpicturism. It can be anything. It may be a tumor, right? It may be an infection, it may be a trauma, it may be a stroke. They all can cause Penn Hyperpicturism. Symptoms of hypothyroidism and hypoadrenalism will be covered in the sections devoted to those glands. We are not going to discuss here. Now, specific deficiencies. Say for example, if one who is having prolactin deficiency because of this underproduction of pituitary, because prolactin is not going to release from the pituitary because pituitary is not functional, it's compressed. There are never any symptoms of prolactin deficiency in men. In men you're not going to see any symptoms, but if it's a female, in women prolactin deficiency inhibits what? Prolactin. Pro means favor of lactation. So of course there will be deficiency, there will be inhibited lactation after childbirth. So prolactin deficiency inhibits lactation after childbirth, and prolactin literally means in favor of, like prolactation. So its main function in favor of lactation. It will help in breastfeeding, right? But if there is prolactin deficiency, then of course we are going to see inhibition in lactation. If deficient, the patient cannot lactate normally. Then we have luteinizing hormone and follicular stimulating hormone. Women will not be able to ovulate or menstruate normally and will become amenorrheic. Men will not make testosterone sperm. Both will have decreased in libido and decreased axillary, pubic and body hair. So secondary sexual characteristics are also decreased. Men will have erectile dysfunction and decreased muscle mass. Of course, this is all because of LH and FSH decrease, because there is decrease in FSH and LH because of prolactin underproduction. Now, FSH and LH abnormalities, the table compares Kalman syndrome and Klinefelter syndrome. If you're considering both the syndrome like Kalman and Klinefelter, especially related to etiology, related to relation to FSH and LH and other characteristic, and how you're going to manage those people who are having Kalman and who are having Klinefelter. So in the case of Kalman syndrome, we are having this mutation, that is Cal1 mutation. But for the Klinefelter, we need to know it's 47XXY karyotyping. What is the ratio of relation to FSH and LH? Decrease FSH and LH from decrease gonadotrophin releasing hormone. GnRH is released from the hypothalamus and it will act on the pituitary and it will ask the pituitary to release FSH and LH. So if there is decreased GnRH, who is going to ask pituitary to release FSH and LH? Definitely you're going to see decreased FSH and LH. In the case of Klinefelter, androgen deficiency through insensitivity to FSH and LH despite high FSH to LH levels. In this patient, there is androgen deficiency. There is androgen deficiency through insensitivity to FSH and LH despite high FSH to LH levels. No doubt FSH and LH levels are high, but you are going to see androgen deficiency in the case of Klinefelter syndrome. Then other characteristic in Kalman syndrome, especially a triad of this decreased FSH and LH and in anosmia and renal agenesis. So if you're seeing any patient who is having anosmia or renal agenesis with decreased LH and FSH, so you must consider that this is a case of Kalman syndrome. In the Klinefelter syndrome, the other characteristic is usually they are very tall. For the management point of view, you have to replace testosterone if it's a case of Kallmann syndrome, and you have to replace testosterone if it's a case of Klinefelter syndrome. So option and management point of view is same for both of them. Kallmann and Klinefelter syndrome, both will be managed by replacing testosterone. Now, growth hormone deficiency, if the patient is having growth hormone deficiency, definitely if the pituitary is not working, then this growth hormone will be decreased. So, children present with short stature and dwarfism. Adults have few symptoms of growth hormone deficiency because several other hormones such as catecholamines, glucagon and cortisol act as stress hormones. Children present with short stature and dwarfism. Adults have few symptoms of growth hormone deficiency because several other hormones such as catecholamines, glucagon and cortisol act as stress hormones. You need to remember these points. These catecholamines, glucagon, cortisol, they all are acting as stress hormones. Adults deficient in growth hormone have subtle findings such as central obesity and increased LDL and cholesterol levels, reduced lean muscle mass. These are all because of adult deficient in growth hormone. The one who is deficient in growth hormone, definitely you're going to see some subtle findings also. You may find central obesity, you may find increased LDL and cholesterol levels and reduced lean muscle mass. Now, how we are going to diagnose these patients, especially those who are having growth hormone deficiency? First thing is hyponatremia. Hyponatremia is common secondary to hypothyroidism. It's common secondary to hypothyroidism. When there is hypothyroidism, thereby you're going to see hyponatremia and isolated glucocorticoid underproduction. Potassium levels remain normal because aldosterone is not affected on aldosterone because aldosterone excretes potassium. So what is actually happening here, that growth hormone is most of the time when TRH, that is thyroid releasing hormone is actually released from hypothalamus, but it will act on thyroid and it will ask thyroid to release TSH. Same time it will release growth hormone also. So if there is deficiency of especially that TRH, or if you're going to see that there is underproduction of especially this pituitary gland, you're going to see growth hormone release will be deficient, and growth hormone again one of the main mediator for the release of TSH, then definitely we are going to see the decrease in TSH, or TSH alone itself can cause hyponatremia. So all of these findings are intermingled. No doubt, aldosterone is released from the adrenal gland. It will release. There is nothing like that aldosterone has to release because someone will going to act on adrenal and will ask adrenal to release aldosterone. Aldosterone release is purely based on renin-angiotensin system. That is not controlled. That is not under the control of any pituitary hormone. So because of the renin and angiotensin system, this aldosterone is released. And when aldosterone is released, the main function of aldosterone is to retain sodium and water inside the body and excrete potassium outside the body. Right? So potassium levels remain normal. This is only sodium levels which you're going to see low, that is hyponatremia, in the case if the patient is having, hypothyroidism. So because of the secondary effects of the hypothyroidism, we are going to see this hyponatremia. Now, MRI detects compressing mass lesions on the pituitary. You are going to check MRI, that definitely going to show you compressed mass lesions. The initial tests for suspected Penn Hyperpicturism are for evaluation that your patient is having Penn Hyperpicturism. That's all levels are decreased. You need to check TSH level, T4 level, this insulin-like growth factor. You need to check estrogen, testosterone, luteinizing hormone, follicular stimulating hormone, prolactin. For growth hormone deficiency, the best initial stimulatory test is injecting growth hormone releasing hormone. This GHRH is actually released from the hypothalamus. It will act on the pituitary and it will ask pituitary to release growth hormone. So if we really want to check that what is the status of growth hormone in someone who is having Penn Hyperpicturism, we can always give this GHRH from outside the body, and we are going to assess the functioning. If the pituitary is severely compromised, and of course by giving GHRH from outside the body, the pituitary is not going to release growth hormone. Other than that, if the patient is not having any problem, then what will happen? If you just give the GHRH even from outside, you're going to see there will be massive rise in GH level, because growth hormone releasing hormone will act on the pituitary and it will ask pituitary to release growth hormone. So if someone's patient's body is absolutely normal and you are giving just this GHRH, so definitely you're going to see rise in growth hormone level, but not in the patients who are having compromised pituitary. Now, so the specific diagnostic test for each hormone, particularly we have standard blood test, and how we are going to confirm with, that is abnormality confirm with, say for example, low thyroid stimulating hormone test, this TSH and low thyroxine level. If you're seeing low TSH and low thyroxine, then abnormality confirmed with decreased TH's response to thyrotropin releasing hormone. This TRH is released from the hypothalamus. You can give this TRH from outside the body if you're just suspecting that, well, I need to check whether this all low because of pituitary or this all low because of, say, something related to hypothalamus. Because hypothalamus is the master gland. It has to release inhibitory and it has to release excitatory neurotransmitter, so that with the help of this excitatory and inhibitory neurotransmitter hormones, those particular hormones are released from the pituitary. So if this TRH is not released from the hypothalamus, then how TSH is going to be released from pituitary? And then how pituitary is going, if this TSH is not released, then definitely T3, T4 will not rise. So if we can give TRH from outside, and by giving TRH from outside still the TSH is not released, then you will definitely come to know there's something wrong in the pituitary. Now, standard blood test, decrease adrenocorticotropic hormone and decrease cortisol level. So if you're finding ACTH low and cortisol low, then what you're going to do, the normal response to cosentropin stimulation of the adrenal. Now, in order to check that whether it's this low ACTH and low cortisol is just because of the hypopituitarism, what we can do, we can just administer this cosentropin. So cosentropin is stimulation of adrenal. If there is normal response to cosentropin, if you just enter this cosentropin, that is just acting like this adrenocorticotropic hormone, if you're just going to administer this cosentropin from outside, and if your patient is absolutely normal, then what will be the response of your patient? Patient's cortisol will rise, because it is a function of the ACTH, is a function of the cosentropin, that it will act on ACTH, it will act on adrenal gland, and it will ask adrenal gland to release cortisol. So if patient is normal, he is not having any pathology, and once you give cosentropin to your patient, and if cortisol will rise, then you will say that adrenal is absolutely normal in recent disease, but abnormal in chronic disease because of adrenal atrophy. So the points are mixed together here. We can say that if there is normal response to cosentropin, then stimulation of the adrenal gland will take place, right? But you can see if adrenal is normal, definitely cortisol is going to release, right? Cortisol will rise because adrenal is normal. So if ACTHs act on the adrenal gland, definitely cortisol will be released. But if there is any abnormal in chronic disease because of adrenal atrophy, you're not going to see anything like this. Or especially in chronic diseases, the response can be changed. We should keep this in our mind too. But if there is no response, that is rise in ACTH level with corticotropin releasing hormone, no response. If you're just giving this CRH from outside the body, this CRH is actually released from hypothalamus. And this CRH, which is released from hypothalamus, it will act on pituitary and it will ask pituitary to release ACTH. So, if you're giving this CRH from outside and you're watching that by giving CRH, the ACTH level is not getting rise, it means that there's some pathology related to the pituitary. That's why pituitary is not releasing this ACTH level. An elevated baseline cortisol level exclude pituitary insufficiency. An elevated baseline cortisol level exclude pituitary insufficiency. If you're seeing cortisol levels normal, baseline elevated, it means that there is nothing related to the pituitary problem, because ACTH is okay, and ACTH is going to act on adrenal and ask adrenal to release cortisol, and that elevated baseline cortisol is also okay. It means that there is nothing related to pituitary insufficiency. Now we are coming towards decreased LH and FSH levels and decreased testosterone level. There is no confirmatory test for these hormones. We have growth hormone levels low, but this finding is not helpful since growth hormone is pulsatile. When the patient is sleeping, maximum, you're going to see the release of growth hormone maximum at night, means during sleeping. So we can check this growth hormone, but again, because of the pulsatile release pattern of the growth hormone, you definitely can't say that this is the good confirmatory test. So no response to growth hormone releasing hormone if you're just giving this GHRH from outside the body, because GHRH is released from the hypothalamus. It will act on the pituitary and ask pituitary to release growth hormone. So if you're giving this GHRH from outside the body, and if you're going to see there is no response to GH, it means that pituitary is compromised. And no response to arginine infusion, again pituitary is compromised. Then we have prolactin level low but not helpful, and no response to TRH, because TRH is thyroid releasing hormone. It is released from the hypothalamus. It will act on the pituitary. It will ask pituitary to do two things. Number one, TRH is responsible to secrete TSH, of course, and TRH is also responsible to secrete prolactin also. This point you need to remember. This TRH, which is released from the hypothalamus, it will act on the pituitary and it will ask pituitary to release not only TSH but also prolactin. So prolactin and TSH both are released under the influence of TRH from the hypothalamus. Now we have some older and less useful tests that we don't need to remember for our exam point of view. Like before, we are using this metapropone testing that inhibit 11-beta hydroxylase, and this decreases the output of the adrenal gland, and metapropone should normally cause ACTH level to rise because cortisol goes down, and cortisol is the feedback inhibition on the pituitary. As soon as the level of the cortisol is rising in the blood, it will do negative feedback on pituitary hormones. That is natural. But nowadays we are not doing it, so you just need not to remember this point. Then insulin stimulation. Insulin stimulation. The normal effect of insulin inducing hypoglycemia is a rise in growth hormone level. Growth hormone increases glucose level because it is a stress hormone. Insulin induced hypoglycemia as a test is always the wrong answer. Insulin induced hypoglycemia. Like once you introduce insulin and you're going to see hypoglycemia, is always the wrong answer. Never choose this. You're not using this method anymore. But we know very well that growth hormone increases glucose level because it is a stress hormone. So the normal effect of insulin inducing hypoglycemia is a rise in growth hormone level. Once you introduce insulin and you are going to see hypoglycemia in your patient, that is all because of increase in growth hormone level. But if pituitary is compromised, you are not going to see this hypoglycemic effect. And growth hormone increases glucose level because it's a stress hormone, and insulin induced hypoglycemia as a test is always the wrong answer. So you just don't need to remember this test. The metapropone and insulin stimulation, nowadays they are obsolete. Now treatment, you have to replace deficient hormones with cortisone. You have to give cortisone, you have to give thyroxine, you have to give testosterone, estrogen, recombinant human growth hormone. These are all your treatment plan. Replaces cortisone before starting thyroxine. You have to replace cortisone once you start thyroxine. Point to ponder. Now posterior pituitary. The two products of the posterior pituitary are posterior pituitary. Actually, we should know this thing, that posterior pituitary is not going to form this ADH and oxytocin. These are actually formed in the hypothalamus and they are going to release in the posterior pituitary. So these are actually formed from hypothalamus, but they are actually stored in the pituitary, posterior pituitary, and they are released from the posterior pituitary. But these are actually neurotransmitters secreted from hypothalamus. So the two products of posterior pituitary are antidiuretic hormone and oxytocin. So there is no deficiency disease described for oxytocin. Oxytocin helps uterine contraction during delivery, but delivery still occurs even if it's absent, because antidiuretic hormone deficiency is also known as central diabetes insipidus. It's not like that the patient is not having oxytocin, so the labor or delivery of the baby will not occur. Definitely that will do, but again oxytocin is required for, first of all uterine contractions and all that, and later on in lactation it will help. So certainly you're going to see something, effect on the lactation and contraction later on, but not during labor and during delivery. Then we have diabetes insipidus. So antidiuretic hormone deficiency, that's a vasopressin deficiency. If there is ADH deficiency, then that diabetes insipidus is known as central one, because this is all the deficiency of towards the central line, like brain and the spinal cord. So brain is involved. Definitely we are going to say central diabetes insipidus. So what is actually diabetes insipidus? Diabetes insipidus is a decrease in either the amount of ADH from pituitary. If the pituitary is the cause in decreasing the amount of ADH, then this is known as central diabetes insipidus, or its effect on the kidney, that is known as nephrogenic DI, or its effect on the kidney. So if you are going to see the effect of diabetes insipidus on the kidneys, especially the kidney means nephrogenic diabetes insipidus, and central means central brain, central diabetes insipidus, pituitary is involved. Now, in the case of central diabetes insipidus, any destruction of the brain, maybe from stroke, maybe from tumor, maybe from trauma, maybe from hypoxia or infiltration of the gland, from sarcoidosis or infection, anything can cause central diabetes insipidus. What about nephrogenic diabetes insipidus? Nephrogenic diabetes insipidus, a few kidney diseases such as chronic pyelonephritis, amyloidosis, myeloma, or sickle cell disease will damage the kidney enough to inhibit the effect of antidiuretic hormone. Hypercalcemia and hypokalemia also inhibits antidiuretic hormones' effect on the kidney. That is again very important. Hypercalcemia and hypokalemia also inhibit antidiuretic hormone effect on the kidney. What is the function of the antidiuretic effect on the kidney? Antidiuretic. Now, your patient presents with DI, present with extremely high volume urine. Of course, this is antidiuresis. In diuresis, you are going to see large or excessive amount of fluid that is lost in the urine. But antidiuretic is the one that will hold the water. It will inhibit the extra release of water. So diabetes insipidus present with extremely high volume urine and excessive thirst resulting in volume depletion and hyponatremia. That is very important. That's why you are going to see here that most of the time, hypercalcemia and hypokalemia also inhibit antidiuretic hormones effect on the kidney. We are just going to learn in detail that why we are having this hypercalcemia and why we are having this hypokalemia that actually inhibit antidiuretic hormone effect on kidneys. So that all depends on the presentation, that all depends on the disease condition, whether the disease is having chronic pyelonephritis or amyloidosis or myeloma or sickle cell disease, that all these diseases will damage the kidney enough to inhibit the effect of antidiuretic hormone. No doubt ADH is there, that's released from the pituitary, but there is a lesion in the kidney, and that's why kidney is not following and not obeying this ADH, and antidiuresis will not be there. There will be less amount of water, there will be more amount of water excreted in the urine and less amount will be retained. So DI presents extremely high volume urine, of course, because antidiuretic hormone is not functioning. It means that there will not be any retention of water. So too much amount of water will be released, and excessive thirst results. Of course, when too much is released or excreted in urine, then plasma volume will be decreased, and because of the decreased plasma volume, the patient must be experiencing excessive thirst, resulting in volume depletion and hyponatremia. Hyponatremia, why? Because most of the time when hyponatremia, if you're considering those who are excessively drinking water because of excessive thirst, it will result in volume depletion. There is volume depletion, right? And thereby you are going to see hyponatremia. And when hyponatremia is severe, there will be neurological symptoms. Or in other words, if too much amount of water is lost, then of course solute concentration, this ions concentration will be increased inside the blood. Thereby definitely you are going to see hyponatremia also. For that reason, hyponatremia, if severe, you are going to see neurological symptoms like confusion, like disorientation, lethargy, eventually seizures and coma. Neurological symptoms can occur only when volume losses are not matched with drinking enough fluid. So, neurological symptoms occur only when volume losses are not matched with drinking enough fluid. The patient, of course, is going to drink. Excessive thirst will be there, but that thirst and that volume of water that he is going to take via orally, that is not quite enough to replace the inside plasma volume. That's why the patient is experiencing neurological symptoms. So thirst, that is excessive one, and if you're going to see the urine volume which is increased, right, because there is no effect of antidiuretic hormone, and when too much amount of water is excreted, in urine, what you're going to see then? Osmolality will be decreased. Osmolality means number of molecules of solute. So too much water, definitely solute will be low. Definitely sodium will be low. Only the water content is released. Now, if we're considering the serum point of it, this is all about urine. In urine, you are going to see this excessive volume of water, right? Volume is increased, mostly contain water. Volume of urine contain water, and number of solutes is decreased. Thereby, you are seeing decreased osmolality and, of course, decreased sodium. But in the case of serum blood, we are considering, we are just going to reverse it. The volume will be low in blood. Why? Because most of the volume is excreted in urine, and osmolality you are going to see increased osmolality. Osmolality means number of solutes you are going to see high in blood. Of course, sodium will be high, and you are going to see hyponatremia. So, if you are saying in someone's patient who is having this excessive thirst, who is having this increased volume of urine with decreased osmolality, decreased sodium, and having serum volume which is decreased and high osmolality and high sodium, then you should proceed with vasopressin, that is desmopressin stimulation test. You should proceed with this desmopressin stimulation test. So, what are the diagnostic tests? Serum sodium is elevated when oral replacement is insufficient. Urine osmolality and urine sodium are decreased. Serum sodium is elevated when oral replacement is insufficient. This is again very important. Your patient must be taking water because he is excessively thirsty, but that oral replacement is insufficient to elevate. Is insufficient in comparison to the amount of solute present in someone's blood. So that's why you're going to see serum sodium is elevated when oral replacement is insufficient. Urine osmolality and urine sodium are decreased because less amount of sodium will be released in urine. So thereby you are going to see the osmolality of the urine and urine sodium are decreased. Serum osmolality, which is largely a function of serum sodium, is elevated. Urine volume is enormous because there is no ADH. So serum osmolality, which is largely a function of serum sodium, is elevated. Why serum osmolality is elevated? Why? Because more amount of solute is there. Osmolality, it depends on amount of solute. So if more solute is inside the blood, the more osmolality will be there. So it's too much sodium inside the blood and less amount of sodium is excreted in urine. That's why you're going to see the high osmolality in blood, because of high level of sodium in blood. Because of hyponatremia, you're going to see high osmolality in blood. But of course, in urine, the osmolality will be decreased because there is low sodium in urine, and you're going to see large volume of urine because too much water is lost in the urine because there is no ADH. This is the whole play of ADH. ADH is not there. That's why we are getting this enormous amount of volume of urine without sodium. The difference between central and nephrogenic diabetes insipidus is determined by response to vasopressin. So difference between central and nephrogenic you have to determine by response to vasopressin. Vasopressin, that is, this is antidiuretic hormone. In central diabetes insipidus, if you're just going to give this vasopressin, right, from outside the body, if it's a case of central diabetes insipidus, then what will happen? Urine volume will decrease and urine osmolality will increase. If it's a case of central diabetes insipidus, it means that pituitary is involved and pituitary is not making antidiuretic hormone. So if you're giving antidiuretic hormone from outside, then definitely you're going to see the function of ADH on kidneys, like the normal function, because kidneys are absolutely normal. There is nothing related to the kidneys. The whole pathology is towards the pituitary. That's why the pituitary is not able to make ADH. But if you are giving ADH from outside the body and you are checking the response on kidneys, definitely kidneys will work normal. And what is the normal work? Normal work is urine volume will decrease and urine osmolality will increase because sodium is going to release and water is going to be retained. With nephrogenic diabetes insipidus, you are not going to see any effect of vasopressin. Vasopressin is just like ADH, but that is you are actually giving outside the body in just order to check whether there is all pathology in the pituitary or all pathology towards the kidneys. So vasopressin is nothing but just a synthetic ADH which you are giving from outside the body, same like the pituitary is releasing. But if the pituitary is compromised, then of course ADH is not going to release from the pituitary and you are not going to get any effect of ADH on kidneys. So with nephrogenic diabetes, there is good quantity of ADH. ADH is normal. There is nothing related to pituitary, but the kidneys are responsible. They are not making or they are not actually obeying ADH. So you are not going to see any effect if the kidneys are dysfunctioning. So there will be no effect of vasopressin use on urine volume or osmolality because there is nothing related to pituitary. That's all disorder lie under kidneys. So treatment option, central diabetes insipidus is treated with long-term vasopressin like desmopressin use, and nephrogenic diabetes insipidus is managed by trying to correct underlying cause. For example, you need to correct hypokalemia, you need to correct hypercalcemia. Nephrogenic diabetes insipidus also respond to hydrochlorothiazide, amyloid and prostaglandin inhibitors such as ANSAs, for example, indomethacin. So you will see the response of all these particular medications on nephrogenic diabetes because these all act on kidneys. So vasopressin desmopressin stimulation test, when you give vasopressin from outside the body, and if you're going to see this is nothing but just like ADH, and if you're seeing that if the patient started there's sudden decrease in the volume of the urine and osmolality increase, definitely you're going to say that pituitary is involved, and that's why we are saying this is central diabetes insipidus, and you have to give vasopressin because pituitary is involved. So definitely you have to give this ADH from outside the body. But if there is no effect on the urine, then definitely you're going to say this is the whole pathology is because of kidneys actually kidneys involved. It's not obeying ADH, right? So that's why you're going to see nephrogenic, you are going to say this is nephrogenic diabetes insipidus, and in that case you have to use medication that will treat kidney pathology like hydrochlorothiazide, amyloid, ANSAs. This is all about diabetes insipidus evaluation. Alright, so I'm just going to stop here. So tomorrow inshallah we are going to continue this endocrinology. Now thank you so much, same time inshallah. Oh no, tomorrow is Wednesday. Alright, I'm going to message you regarding tomorrow's timing because tomorrow is my stay back. Thank you dear, thank you.